what happens with the UV, it causes molecular changes in the melanocytes, and they start growing rapidly, causing melanoma.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Merve Hasanov. Merve is a medical oncologist and a melanoma expert who treats patients at the James and is involved and leads cutting-edge research and clinical trials that focus on how melanomas metastasize and can spread to the brain. Skin cancer and melanomas are among the most common types of cancer, and Merve will fill us in on what they are, the current treatments, what's next, and her research. Welcome to the podcast.
Hello, Steve. Thank you so much for having me.
This is a very important topic because skin cancer and melanomas are, and you'll correct me if I'm wrong, the most common forms of cancer, I believe. And so before we get to your research, which is really interesting, let's focus in on a little bit about what people need to know about melanoma and skin cancer.
So when we talk about the skin cancer, it includes an array of cancer types, right? It can be squamous cell cancer, basal cell cancer, melanoma, Merkel cell cancer. So those are all different skin and skin appendages related cancers. So melanoma is amongst of all of those is the deadliest and the most really serious form of the skin cancer. So that's why we have a lot more in-depth research in that area, and so it's projected that every year it's about like 20-30% there is increase in diagnosis for melanoma from stage 0 all the way through stage 4.
So every year 20 to 30% more cases. Wow. Do you know why?
It's a total when you look at from over the years. So there's like the projected increase. I think there is two parts to it. So we have better screening, better really people being aware of the skin cancers and melanoma overall. So it's more and more being recognized, and the patients are seeking really screening exams and all of that. And also, so there is more sun exposure in the population, but I would put more towards the being aware. All of our really work into this.
So you mentioned sun exposure, and I'm guessing that's probably by far the number one cause?
Correct. So how melanoma, when we look at how melanoma is formed, right? So we have melanocytes that forms the melanin pigment of the skin. So that gives the protection from the UV light that we have. So exposed from the sun, but also includes all kinds of UV array exposures. And that's amongst the first and the most. And it's not just one-time exposure, it's lifetime cumulative exposure that we're talking about. So there are some patients that are at higher risk of developing melanoma, such as fair skin, fair eye, fair complexion patients, but it doesn't mean they're the only ones that are at risk. There are some familial genetic causes to this, but also there are other types of melanoma, not just the skin melanoma that we can talk about. The other patients are at more risk about.
Well, two things. First, people with darker skin can still get it, right?
Absolutely.
It's just less common.
Absolutely. So they can still get it, and especially we see when we look at the melanoma, it doesn't just start from the skin. So it can start from under the nail beds, which African American people are found to be at higher risk to develop. Those are called acral melanomas. There are eye melanomas, which we call them uveal melanoma. So there are melanocytes, believe it or not, in the eye, so they can turn into melanomas. There are also something called mucosal melanoma that can develop inside of the body, like inside the nose, inside the genital parts, gastrointestinal system, anal region. So it's common. It's a whole range different of melanoma types, but of course the skin melanomas are amongst the most common.
So if we know that either you're genetically predisposed or of course UV, what can we do to protect ourselves and reduce our chances?
Right. So sun exposure is not just the only UV exposure, right? So tanning beds were very common in the past. Even the teenagers and very young women were getting that to look the best of their shape, and nobody knew about that would end up causing melanoma. So
because that they utilize UV rays.
Correct,
right?
correct. So what happens with the UV? It causes molecular changes in the melanocytes, and they start growing rapidly, causing melanoma. So the protection comes from decreasing our exposure to any form of UV, to sun blocking or avoiding tanning beds. So how we can do that? Using sunscreens and using hats, using, if possible, long sleeves, long pants when it's very hot, especially high in the summer. Not just, I wouldn't talk about summer. Whenever you get outside, there's always UV rays. Even if you see like, oh, it's cloudy, but there is still UV rays coming from the sun that can predispose you to the exposure. Maybe less likely, but it is still. So I recommend all throughout the year, whenever you're getting outside, using the sunscreen, but more so especially in the summertime. And we shouldn't forget about reapplying the sunscreen. So whenever you go into water, it's going to wash off. So you have to reapply every 50, 90 minutes, depending on the factor of it. So you have to reapply the sunscreen if you're outside.
It's kind of amazing. During my lifetime, when I was in my teens, we wanted to get tan.
Right.
And we put things on our body that would probably, I'm guessing, increase the UV rays going. And now we've learned that
increase
this is...
the burning so that it's going to turn.
Well, so we don't turn red, but we turn darker, but not redder. And we've learned that this is not the right thing to do and is dangerous. And it's amazing how much we learned. Yeah. And also, and some others have talked about this, that the advances in treating melanoma have really increased. So again, we could do multiple podcasts just on that topic, but
absolutely.
Quick overview, what are some of the latest and best treatments that the patients you see who have melanoma?
Absolutely. So I want to break it down to the stages and how we approach to the treatments, right? It's not just the stage 4, advanced stage that we're talking about right now.
When you say stage 4, meaning it has metastasized and spread.
Metastasized, exactly. Okay. So we can start, stage 0 is melanoma in situ, when it has not gone deeper and formed the actual melanoma, but it's precancerous lesion, and that's treated with the surgery. And when we're talking about stage 1 and stage 2, it's still originated. I'm just talking about the skin cancer right now, so it's different for other forms of melanoma, but the skin melanoma, so when we're talking about stage 1 and 2, it's on the skin. So it's gone deeper, which we call it Breslow thickness, so depth of the invasion of those melanocytes that are growing, but they have not spread to lymphatic system, which includes our immune cells, or the bloodstream. So still in the location of where it's originated in the skin, but gone deeper, either stage 1 or 2.
So stage 2 would be deeper, but not yet metastasized.
Correct. Okay. So it will be either deeper, and also we have something called ulceration. So when we take a piece of the melanoma and look under the microscope, we can tell if there is ulceration or not. So pathologists are trained to do that. That also gives us if it's deeper and ulcerated, so it is more onto the stage 2.
What is ulceration?
So the look of it is different, more inflamed, and so pathologists are trained to really differentiate it. So it's kind of a pathological look under the microscope that we can differentiate.
Okay, under the microscope, but perhaps what should people look for before we get into the more other stages? What should people look for in their own bodies that they should then say, oh, I better have my dermatologist or primary care physician look at this?
Absolutely. So without any even moles, it's now recommended that we get once a year dermatology checks for a full body skin exam. But there are ABCDEs, right? We've all heard about. So when you look at a mole, let's say asymmetry of the mole. So you put a line in the middle, and then those look a bit weird. And you look at the borders of the mole, and it's like a bit irregular, not just round or oval, but instead it's a bit like ragged and
that's the B.
Yeah,
borders.
That's the B. And the C is the color. If there is color change. And also, when you look at the mole, it's like a little lighter in one area, a little darker in another area. It's also suspicious. And the diameter. So it's if it's more than 6 millimeter, it's like a tip of back of the pencil. That's basically like what we measure it for. So if it's larger than that, it's also concerning. And E, evolution. Has it been changing? Has it all of a sudden started growing and changing in color and bleeding, itching? So that those are all alarm signs that requires a dermatologist evaluation.
Okay, good. The A, B, C, D, E, and you talked about stage 1 and 2 that surgically removing is often. Yeah. So what happens with the treatments for the later stages?
Yeah. So when you come to now for stage 2, when there's like prevention treatments, we discuss if an immunotherapy is a good option for a patient to prevent cancer from coming back. When you move to the stage 3, there are 2 approaches. In the past, we were having surgery and a sampling of a lymph node that potentially melanoma drains to, and surgeon would check for it if there is available or not. And after that, we would discuss if it is a good option for patients to do immunotherapies or some form of targeted therapies molecularly directed towards any changes in the melanoma itself to see if we are able to decrease the chances of melanoma coming back. But now, with more studies and clinical trials that we've been running, we're showing more that the outcomes are much better in terms of, we call it recurrence, which when the cancer comes back, it is much better if we do immunotherapies early on before the surgery. And it is some still in the clinical trial phase, but it is gaining more and more attraction that we're seeing. Perhaps it's much better to do immunotherapy beforehand when the immune cells are trained for the cancer, much more available, so we can make it more robust towards the cancer treatment.
So we just recently on the podcast, Matt Old from Head and Neck Cancer was on saying the same thing with head and neck cancer, immunotherapy before surgery, because it pre-trains the immune system to recognize the cancer cells. So you're like kickstarting it earlier, which is fascinating. So that's a growing trend. And
absolutely.
And I've heard, and people have talked that immunotherapy, even at the earliest uses of it, skin cancer, melanoma was always a good target. What makes immunotherapy seem to be as effective for skin and melanomas as any type of cancer?
Right. So melanoma is an immune hot cancer. What it means, melanoma has lots of molecular mutational changes in the melanomas itself, genetic changes, right? So when we were back in the beginning of the talk, we were talking about the UV, how it changes the molecular material of the melanoma or the melanocyte so that it starts growing and dividing in a fast rate, forming the cancer. So because of those molecular changes, there are unknown, unrecognized proteins that are released from the cancer. So those are recognized by the immune cells. So melanoma is a perfect one because there are lots of changes and they are producing lots of proteins, molecules that are alarming the immune system to be activated, and then they're hot and ready to do that. But cancer is smart, so they can shut down the immune system. So that's why we use something called immune checkpoint inhibitors as form of one of the immune therapies to take the brakes off the immune system so that there are more active T cells, which are the immune cells fighting against the cancer, can go and recognize those cancer cells and kill them. So those are kind of the makes what melanoma more prone to be getting positive results from immunotherapy.
It can detect targets better than in some other cancers.
Yeah.
Okay. That was a great overview. And before we kind of wrap up that part, I think everything you said and what others told me is gives me the reason why people should be treated at a comprehensive cancer center where they have experts like you. What about a comprehensive cancer center in the James makes it the place where people should be treated?
Yeah. So James is the National Cancer Institute designated comprehensive cancer center, which means we have availability for all form of research, all form of multidisciplinary approach, and really world-renowned experts in here. So most of our medical oncologists, radiation oncologists, surgeons, they see only certain type of cancer patients, and they see many of them, and they do research, they follow really all the research available and contribute to it. So we have clinical trials, we have all the most cutting-edge treatments that are available can be given only in the really comprehensive cancer center. So we have all that available here in a multidisciplinary approach with really great patient care approaches.
So experts like you.
Yeah.
And when we come back, we're gonna take a quick break, and when we come back, we're gonna learn more about your research, which is really cutting edge and great.
Thank you.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back, and before we you start telling us about your research, I think we need to cover a little more. I neglected to let you finish on stage 4 treatments.
Yeah, so stage 4 is when we see that melanoma has spread to where it's originated from the skin and around the lymph nodes to either distant lymph nodes or distant organs, including the brain. So we have immune therapies in forms of immune checkpoint inhibitors that we talked about in stage 3 cases, and also targeted therapies, which are directed towards some molecular changes that happens in the melanoma itself with outside exposures or sporadically, which means all of a sudden, we don't know why, eventually, they form those mutations, genetical changes in the molecular genetical material in the melanoma, and we have targets for it thanks to the clinical trials that I have done and now approved.
How is targeted therapy different from immunotherapy?
So immunotherapy is basically affecting your whole body and activating the immune system. And
the immune system goes throughout your body, whole body, looking for the cancer.
Right. So who is doing the job is actually your own immune system, right? So it's activating the immune system, taking the brakes off. So it is whole activated and affects the whole system. So that's why some of the side effects come from. And the targeted therapy only affects the cells that are actually have that mutation. So if, for example, one of those mutations that we're talking about is a BRAF mutation, another one is KIT, KIT, NRAS mutation, those are all the potential mutations that we have targets for in melanoma. So the most common one is BRAF mutation, and we have melanoma, skin melanoma patients, about 50% of them has BRAF mutation, and we have in the pill form treatments against it because those systems, that's a growth signal. In the think about this, in our cells, we have all the cell components, but also electrical molecular systems that gives us, the cell should divide, cell should grow, cell should develop into invasion and going into the bloodstream. So those are all different types of signaling systems. And when it's altered because of those mutations, it gives the growth signal and constantly. So if you give that molecular target and shut down that electrical system, that switch is turned off. So the cancer does not grow, in fact, starts dying.
Okay, good. I'm glad I now understand the difference between immunotherapy and targeted therapy. And that leads perfectly into your research, which you're going to, of course, give more details, but it's about when it metastasizes to the brain, which I'm guessing is one of the more serious and problematic places it can metastasize to.
Right. So brain metastasis is really the, when we look at the stage 4, we have even the letters that comes in our offices, patients here, stage 4 M1D. We have ABCD, depending on which organs are involved. Because brain metastasis, they behave differently. We identified a new, we call them M1D. So it's more technical, but basically those patients' outcomes have been very, very bad in the past. When we're looking back in 10 years ago, it's about, when we're talking about a brain metastasis patients, was about 6 months of survival. Now it has been much better because of the treatments that we have developed and also the screening measures that we are developing with more frequent screening. Patients and also physicians are more recognizing that entity. But it still remains the most unmet need, unfortunately, at the moment. It requires a multidisciplinary approach with, it's not just the medical oncologist itself, it requires approach and evaluation through neurosurgeon, radiation oncologist, neuro-oncologist, because patients can present with either symptoms or asymptomatic, thanks to our screening measures that we are doing as medical oncologists while we're treating the rest of the body. We're looking into the brain as well.
Oh, so a patient could have a melanoma, it's spread to the brain, but they have no symptoms.
Correct.
But because you're so thorough, you check there anyway through screening and imaging and determine if it's there or not.
Yeah. In fact, we want every melanoma brain metastasis patient to be really detected that way. The reason why our current treatment options that are available, and when we look at how patients do, if they present with symptoms versus without the symptoms in the brain. If they present with symptoms, what are those? Are seizures, headaches, vision changes, any kind of neurological symptoms that might include weakness in one hand, numbness, any like a balance issues. So all of these symptoms in the mild or the severe form should have us think about, can there be a melanoma brain metastasis? But if the patient presents with those, then the response rates to the current treatments that we talked about, immune therapies and the targeted therapies, are much, much lower. So then it's harder to really manage those, and the outcomes is a lot worse than how we would really find out with the asymptomatic patients without the symptoms. And just with the screening images, we found out there's a brain metastasis, and we had the appropriate action either in the form of a systemic therapy with immune or targeted therapies, or radiation, or sometimes less likely for asymptomatic patients, but it might be because of the location in form of surgery. Then they have much better outcomes in form of cancer-free time and also the overall lifespan.
So where does your research take off from this point?
Yeah. So when I mentioned you that if we find the patients asymptomatic, we have much better options for them to manage.
Is that because the cancer probably is not as advanced and large within the brain?
Correct. Yeah. So both of it. They're either smaller or they haven't caused any issues that melanoma causes, like edema in the brain or bleeding into the tumor and in the brain itself that's causing the symptoms. So it's a lot easier for treatments to work against them and control it and really keep the cancer at bay. So our current guidelines does not really recommend stage 1 and stage 2 patients to be screened for brain metastasis. Even for the stage 3, it depends on where you're going, where you're getting your care. In a community setting, you might not be getting a screening for brain for a melanoma patients, even in the stage 3 cases. Most physicians at least does once in the stage 4 in melanoma patients, but even that is not as consistent. So knowing that the asymptomatic patients do better and they have better chances of responding to treatments and have a better survival, we need to identify how, when, and who we should really screen for when we find the melanomas in the early stages. In fact, that's the most common. Most of our patients we find out when they're stage 1 and 2, and some in 3, and we don't really look at their brain. So that was the problem, and we ended up seeing about 12% of them present with the brain metastasis in the future.
Okay, it's 10 to 12% of stage 1 and 2.
Correct.
Melanoma patients will eventually,
And it's a lot higher for stage 3, and for stage 4, it's up to 60 to 80% ended up getting melanoma brain metastasis. So it is very, very important. Melanoma is actually the solid tumor that has highest propensity to go to the brain. Maybe number-wise, we're not the highest number, but if you look at the percentages of melanoma patients that goes to the brain, that is the highest solid cancer type that we're talking about. So it is very, very important. My research focused on first, what are the outcomes depending on which patients, what type of brain metastasis, the features, and their outcomes, and what is the area of unmet need that we need to focus on. And we have seen symptomatic brain metastasis is one of them with the worst outcomes. Leptomeningeal disease, which is when melanoma spreads to the lining of the brain and into the fluid in between the brain and that lining. So that is another area of unmet need when we have too much burden of disease, and if they previously failed immunotherapy prior to developing brain metastasis. So those are the potential patients. But seeing those, symptomatic patients, having one from my study and one from other clinical trials that we don't have much options for those patients, then brought me back to what can I do to really predict those patients who is going to develop brain metastasis in the future, find out about them, and then screen them early on so that we can detect whenever it's early, so that give them a better treatment chances and hopefully better survival. But it's many, many patients. We're talking about maybe 10-12% of patients that are going to develop the brain metastasis versus 80-90% will not. So we have to really recognize them. And I started out with the looking at the patient features and the melanoma features, how they present. And I have, with my colleagues during my training, I developed a calculator actually with a few features of the melanoma and the patient itself. So to give them a potential predicted cumulative percentages that they might develop in the 2, 5, 10 years' time.
So you come up with an actual, I don't know if score is the right
Correct.
word.
Yeah,
an actual score of your odds of developing a brain metastasis down the line, that and the higher that is, the more you're going to screen and catch it earlier.
Correct. Yeah,
Okay.
because we're talking about just selecting those high-risk patients so that it is not nerve-wracking for patients to get unnecessary testing and finding out indeterminate things that's gonna really affect the patient's lives versus really finding out the high-risk patients and doing that for those patients that are very high likelihood, and it's gonna save those patients to be able to get to the treatments, but also save the other patients that are low risk from medical expenses, unnecessary anxiety, and all that. So I started out with that, just with the patient features and the melanoma features when we take the biopsy out or the surgery out and look under the microscope and determine the features. So my next step was to, okay, what are the molecular features? So we talked about a lot and how we develop the treatments depending on the molecular features of the melanoma, and we have a lot more studies ongoing to be able to develop new agents for those patients. And we took primary melanoma samples when they had their biopsies and then had their genetic material read out and figured out, okay, what are the changes molecularly? And we were able to show some associations that are potentially higher likelihood of developing brain metastasis. I also partnered with our industry partners to test some of the commercially available tests to give those genetic testing to see if any of those tests available can predict the development of the CNS metastasis. And we have seen one of the tests that we have partnered with one of our industry partners that showed 9-fold increase in CNS metastasis risk if they have a certain genetic molecule scoring. So it's fascinating. So all three of them, whichever setting the patient has the availability, even in the community, they haven't tested anything. Let's say they have their own information and also the pathology information. So they would be able to use that calculator. If they have better access to those tests that we're talking about, that they can get a molecular testing and use those testing, they will have a second layer of information. Okay, now my clinical features plus my molecular features really points me towards the CNS metastasis risk at a very heightened rate compared to my other patients that might be diagnosed with stage 1, 2, then that gives the physician more information. Okay, we should definitely do those CNS imaging. And we're hoping to gather around all this information and talk to our experts, other experts in the field, so that this can go into guidelines and more physicians can utilize those information.
Yeah, as you were discussing this, that's what I was thinking. Do you have a name for your scoring system?
It doesn't have a name, but we have a link. The
Hasanov scale.
It's a Hasanov scale. So it was a teamwork. So definitely, yeah.
But I'm thinking, as you were saying, more physicians that eventually that all over the country and world, people will use. Other oncologists will use this scale on millions of people.
Correct.
And detect things earlier and save lives.
Absolutely, yeah. So that's our goal. So we're working on the manuscript, all that, to be able to reach more physicians and experts in the field to also gain their usage. But in the region, whenever I've made the presentations about this, several of our colleagues reached out to me. I provided the information, and they've in fact started using.
So others are already starting to use what I'm just going to call the Hasanov scale for now, but until you come up with your official license name. Okay. Yeah. Well, that's pretty amazing that you've done this. And another thing I found interesting, your husband is also an oncologist here at the James, and you two have teamed up a little bit. Fill us in on what you're doing together.
Yeah, so we go back to medical school. We've received our internal medicine training and medical oncology training together, and we have, despite working with different mentors along the way during our training, we have developed interest towards the brain metastasis. So I'm in the melanoma field. He works in the genitourinary field, more focusing on the renal cell carcinoma. And both of our passion is to really help brain metastasis patients, because that's the most challenging right now, and we're developing better and better treatment options for many cancer types across, and that's alongside the solid tumors. Then we're seeing more and more brain metastasis, even in the rare cancer types that we have never seen before with the brain metastasis. So it's not just the breast, lung, and the melanoma anymore. We see all different types of cancers. Patients are developing brain metastasis, but because the attention is fairly near in many of those, and those patients require multidisciplinary approach, and those patients require research in different fields, in the prevention setting, in the treatment scale, in the prognostic, the outcomes scale. So we have teamed up in to be able to help move our forces in here at the James with the mission to be able to merge our forces with everyone that works in the brain metastasis field here, to merge our forces to develop a brain metastasis program and potentially a multidisciplinary approach together.
That seems to be the future and the current, the idea of multidisciplinary clinics, bringing experts together, and a patient comes in and sees everyone they need to see and gets the best possible experts in care, and you're working to create a multidisciplinary clinic for brain metastasis patients.
That's our goal.
Wow. That's a pretty lofty goal. And what kind of motivates and drives you to reach for these big goals?
Yeah, so it's something never stops in you. So anything probably in the medical field, especially who chooses academic medicine, is striving for what's next. What can I give my patients better options? How can I really bring in better care for my patients? They can be treated. They can live longer. Hopefully we can erase the cancer, but if we cannot erase the cancer, maybe we can turn it into a chronic disease like a hypertension, diabetes, that they can take their medications and with minimal, hopefully, side effects can live. So all these goals driving us, and I'm seeing from different ages of patients, and I'm witnessing their lives and becoming part of their lives, how they're struggling, their diagnosis, their treatment, their toxicities, and we become one whole together, walking the path together, and that really drives me to be more motivated on continuing on this research and spending more time to be able to bring more quality of life and also treatment options for the patients, and hopefully some prevention strategies so that we don't need to even deal with those treatment options in the future.
Yeah, the best treatment is prevention.
Yes.
Right? And the next best is what you're working on.
Yeah.
Well, thank you for sharing all this great research and advice and knowledge about melanoma skin cancer and what's coming next.
Thank you so much.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.